Homeostasis is the maintenance of equilibrium in the body, and the kidneys play an integral role in this maintenance. The role of kidneys in the body is to filter waste materials from blood and expel them from the body as urine. Kidneys are critical to the production of vitamin D, red blood cells, and hormones that regulate blood pressure. Kidneys are made of millions of small tubes called nephrons, which are surrounded by capillaries. Blood arrives at one end of the nephron at very high pressure, which forces small molecules out of the capillary and into the nephron. The loop of Henle controls concentration of urine. Going down the loop, useful molecules are reabsorbed into the blood. Going up the loop, water is reabsorbed. Antidiuretic hormone determines the amount of water reabsorbed. ADH determines how permeable the walls of the nephron are. Less ADH means that the walls of the nephrons are less permeable, so less water is reabsorbed and more is lost in urine. More ADH means that the walls of the nephrons are more permeable, so more water is reabsorbed. In the collecting duct, some more reabsorption occurs, then the final product is excreted.
Chronic kidney disease describes a gradual loss of kidney function. During the early stages, there can be few symptoms or signs, which can cause people not to realize until kidney function becomes significantly impaired. However, during the advanced stages, dangerous levels of fluids, such as waste, can build up in the body, and the disease can progress to fatal kidney failure. The two main causes of kidney disease are diabetes and high blood pressure, which accounts for 2/3 of all chronic kidney disease cases. Diabetes is when blood sugar is too high in the body and can cause damage to the organs. High blood pressure, also known as hypertension, is when the pressure of blood against the walls of blood vessels increases. This can cause heart attacks, strokes, and other complications. People suffering from chronic kidney disease can develop complications such as high blood pressure, anemia, weak bones, poor nutritional health, and nerve damage. Chronic kidney disease affects about 11% of the U.S. population and is associated with increased risk of cardiovascular disease. Cardiovascular disease refers to heart disease, which can include blood vessel diseases, heart rhythm problems, and heart defects at birth, although it generally refers to conditions that involved narrowed and blocked blood vessels. Cardiovascular disease can lead to many heart-related complications and includes numerous problems such as atherosclerosis, which is a condition that develops when plaque builds up in the walls of the arteries, causing it to become more narrow and harder for blood to flow through. It also includes other problems such as heart valve problems, arrhythmia, heart attacks, and strokes. Cardiovascular disease affects greater than 1 in 3 adults in the United States and is the leading cause of death in the United States. However, many forms of heart disease can be prevented or treated with healthy lifestyle choices.
Because those with chronic kidney disease are at an increased risk of having cardiovascular disease, many wonder if the same type of association between salt intake and chronic kidney disease applies to cardiovascular disease as well. There is a positive association between sodium intake and blood pressure. However, this does not clearly indicate any pathway to cardiovascular disease. The blood pressure of patients with chronic kidney disease is more sensitive to high sodium intake than people with normal kidney functions due to the diminished capacity to excrete sodium. Because excess sodium builds up in the body, water retention increases, thus increasing blood pressure. So all in all, we need salt in order for our kidneys to do their jobs, but too much can have detrimental effects. Also, by ingesting too much salt, the higher blood pressure puts extra strain on the inside of the arteries. This causes the artery walls to thicken, thus decreasing the space inside the artery, which further increases the blood pressure. This prolonged positive feedback loop can cause arteries to clog up or even burst. If the arteries are clogged, the part of the heart that receives the blood won't receive as much oxygen as it should, resulting in heart pains and poor heart performance. If the arteries burst, the heart will not receive any oxygen and will subsequently fail, resulting in a heart attack. The implications of salt intake on the probability of cardiovascular disease in people affected by chronic kidney disease are studied and discussed in this one particular experiment.
This study used 3,393 diverse adults whose ages ranged from 21 to 71 years. All participants had mild to medium chronic kidney disease and met age-specific estimated glomerular filtration rates. Study participants were requested to collect 24-hour urine specimens at the start of the experiment and at the first 2 annual follow-ups. They attended annual clinic visits and received telephone calls every 6 months between in-person visits. The study found that the mean 24-hour sodium excretion rate was 3,701 milligrams per 24 hours. Participants with higher levels were more likely to be male, white, Current smokers report a history of hypertension, diabetes, cholesterolema, and cardiovascular disease, as well as having a history of taking antihypertensive medications. Those in the highest quartile of calibrated urinary sodium excretion were at an increased risk for composite cardiovascular disease, congestive heart failure, myocardial infarction, and stroke when compared with the lowest quartile of calibrated urinary sodium excretion. This figure, taken from the study, shows the probability of heart failure for each of the 4 quartiles of calibrated sodium excretion. It shows a significantly higher probability of heart failure among those in the upper quartile, while the lower 3 quartiles share lower probabilities. These results document a significantly increased risk of cardiovascular disease in individuals with the highest urinary sodium excretion, independent of several CVD risk factors, including age, race, gender, and smoking history. Findings were consistent across subgroups and independent of further adjustment for caloric intake and systolic blood pressure. Overall, the results of this experiment suggest that moderate sodium excretion amongst patients with chronic kidney disease who have high sodium intake may lower CVD risk. While this is the first study to link sodium excretion and CVD risk incidence in patients with chronic kidney disease, other studies have found links between lowering sodium intake and improved blood pressure. One such study, conducted by Hiddo J. Lambers-Hirsping, found that even a modest reduction in salt intake was responsible for lower blood pressure and better overall outcome. While further studies and clinical trials are needed, reducing sodium intake among patients with chronic kidney disease could be a promising therapy in reducing the risk of cardiovascular disease.